Okay, great. I am here today with Mehmet Gem, who is a good friend of mine. We used to work together at Nuffield Health on the ALP service, and spent most of our time just DMing each other jokes and not really being as professional as maybe we could have been. But it was pretty good because we spoke a lot, and he has a new course all about the hip. So I wanted to get him on to just talk some simple introduction stuff to assessing the hip, really, and hopefully that'll give you a good teaser of what he does on his new hip course, which covers, am I right in saying, literally everything about the hip?
Yeah, I'm going to shoot myself in the foot with that one if I say everything. But yeah, we're just trying. It's a way of just trying to simplify it for clinicians that find the hip daunting. So there's a lot of content, but it's also condensed into what's relevant and just so things people can take away from it and actually feel like they're a bit more confident to assess and treat a hip. Because I know that we all have areas of places in the body which we're not too confident in. So yeah, I'm just hopeful to help some clinicians out, really.
Perfect. Yeah, we'll talk about the old leg shoulder. That's what we should describe it as, I think, sometimes. Perfect. So the first thing I wanted to just ask you about is something I think that a lot of people really are confident in almost every other part of the body, but I never see it done in the hip, and that's visually assessing the hip. So I just wanted to get your take for just a few minutes on what we can look for visually when we look at the hip, and what should we do to do this properly? Because that's the other thing I think about the hip is probably people don't get people undressed enough. I might be skipping ahead of into your answer, but just tell us a little bit about that.
Yeah, and it's an interesting one, isn't it? Because it's probably one of the first things that you get taught as a physio. Let's look at posture, let's have a look at your shoulders and your back. And then much like everything with physio, as the years go by, you end up kind of disregarding everything you've got taught, and then just, you progress as a clinician and critique it. And it's kind of similar with the hip, but the hip and the pelvis does have a bit more of a factor to play in a few ways, really. Now, like we know, like different hip issues will present in different ways, and different demographics will present with different issues. So it's tricky to kind of like isolate and kind of have a broad answer to that, Jack. But there's a couple of things that we could touch on. I think, firstly, try not have an understanding as to how that pelvic, if we call it like pelvic posture, to me, pelvic posture is how is someone standing up. Are they standing in a degree of anterior tilt? Are they posterior tilted? Are they kind of slightly kind of flat back with their posture? Because although on the face of it, it's easy for us to say, look, everyone is different. We've got lots of variety, and skeletons are different, and that's true. And that's essentially what we need to be aware of. That has an impact on how the hip mechanics are. And just how people move as well. And I think that's important when we start to go from the assessment into the treatment programs of these hip patients. So then we have a clear understanding as to how we're going to give them exercises. A key example, and one thing I always come across, or have done in the past, is when you hear like patients who are given squats, like hip patients who are given squats. Commonly you'll hear the old, keep your feet shoulder width apart, keep your toes pointing straight, don't let your knees go over your toes. It's quite a lot for someone to take in. I mean, I can't even follow two instructions, let alone all of those if I was doing a squat. So it's hard to kind of like keep on top of it. But when you're giving advice like that out for patients who have hip pain, it's sometimes not always the right information, in the sense that these patients have retroverted hips, they have anteverted hips. That means that the position of how their hips will rotate will be different. Some will have more internal, some will have more external. And when you're looking at someone's posture in standing, how they are standing, how their feet are pointing, how their pelvic position is, that's quite important when you're then giving them exercises to do, because you don't want to provoke their symptoms. So for me, like, that's how I kind of look at posture. So visually, yeah, I do definitely get them to take their t-shirt off. I always look for patients to have shorts on and things like that, just so we can get a clear understanding of that, really. But look, I like the hip. So the hip is all about bums and groins, really, isn't it? So I'm always going to kind of like want to have a closer look into that. And also gait posture for me is the other thing. So, patients who have pain, whether it's FAI syndrome, whether it's, great gluteal tendinopathy, for me, we're going to pick up loads of information from when that patient first walks in, really. and that's going to be given to us. That info is already there for us. And a lot of the emphasis that I put on the course, and when I do any teaching really, is to try and steer like junior clinicians and just clinicians in general away from being too focused on doing like clinical tests really, and trying to diagnose something by getting their hands on someone and doing something to diagnose it, and actually focusing more on the two really, what I find even of the greatest significant aspects, which is verbal cues and visual cues. So if you sit down and talk to a patient and, you know, spend the time to look at how they're sitting, body language, body posture in that, for that example, and get a clear understanding as to how the symptoms are affecting them, I think that has a massive impact in so many ways. So it's, yeah, you know, we're kind of touching on posture and in regards to that, like gait posture and how they're moving, but it also gives us a little bit more of an understanding of how the patient's being affected really. And you know what it's like, patient alliance and getting into that rapport with the patient is basically the be all and end all of physio, because you could be an average physio and excellent at building that rapport and communication, and you probably still get good outcomes. And then the flip side, you could be extremely well academic and really, you know, well versed in all the kind of literature, you know, but if you can't talk to someone or kind of like build that relationship, sometimes it's a bit of a hindrance. So, you know, for me, it all has an interlay, and you can kind of see we've gone from posture into that. And, you know, I think that's really, really, really important, really. But that's a good way of digressing on a question that you've asked me and covering a few bases. There you go.
Yeah, it is. You get you very politician's answer, answering something else. I was just wondering if is there anything anything around that hip and pelvis area that you would say visually you see it and you go, that's either a big problem or that needs further investigation? Is there anything from that point of view visually? Because I think, again, it's easy in that region. It's like you said, it's bums and groins. That's quite a big area to be looking at. And it's, even if you're comparing left and right, you know, it's quite a challenge. Is there anything, you know, an easy example would be whether there's a big shift sort of laterally or something like that. I'm just using it as an example because it would be something obvious that you could see. Whether it's relevant or not is another question. But is there anything like that where that would trigger you to go, oh, actually, this could be a big problem?
Yeah, I wouldn't say so with the hip and pelvis. It's definitely one of those. I'd say, like you said, because it is such a wide area and a large area that's covered, it isn't always as simple. Like, it's, you know, with an Achilles, you can see it, it's swollen, it's obvious, it fits that clinical picture, and you can kind of, you know, see it. Whereas with the hip, it's not always that straightforward, you know, especially with an intra-articular issue, whatever that may be, OA and, you know, FAI and things like that, labor issues. We're not going to see anything visually if they're just standing there or lying on the bed. But with that, it's more of a kind of emotion disorder, or are they moving differently, or are they sitting differently, or are they standing differently? So from that aspect, those are the kind of things that you'd see, but you definitely wouldn't necessarily visually see something unless it's, you know, like a traumatic injury. You know, if you have like hamstring ruptures, that's a tasty one. You know, you're going to see a fair amount of hematoma and kind of bruising and things from that. But with the hip issues, they're not so much. And yeah, you will get the old kind of like lateral shift, like you said. That's quite common for a few pelvic issues. But I'd say the other element would be those who have, let's say, symptoms that don't fit a picture or a pattern that you would commonly see within the clinic, and then you're kind of thinking, oh, okay, well, look, what else could it be? Because actually they're in a lot of pain, like nothing fits, but they're like unable to weight bear on one leg, and that for me is sometimes a bit of a flag to think, oh, look, what other things could cause that hip to be that painful, but with like no specific pattern. And that's when we'd start to probably question things a little bit more specifically into, you know, like red flags and things like that, because we'd always be cautious of any like bony integrity loss and things like that might be causing them to do that. But I guess in answer to your question, in short, yeah, there probably isn't a direct thing that I would always go and look at visually and just see. But I guess it fits a similar pattern to most things. That Achilles one's actually, I think Achilles and patella is the two things that we can commonly see with the tendon swelling, can't we? But not so easy with the hip, I'd say.
Yeah, fair enough. I was going to make a joke about sort of seeing piriformis syndrome would be a good one, wouldn't it? But anyway, let's stay away from that. That's not a conversation for today, is it? You mentioned sort of red flags and questioning. We'll come on to that in a minute. I was interested. You were talking about posture, and then we digressed into sort of you said about sitting and asking them questions and things. What are there any key questions that differ in the hip that help you to guide differential diagnosis compared to other areas of the body? Is there do you go down different routes for the hip compared to other locations?
Yeah, I do, and I think we should do, and it's definitely something that I try and touch on the course, just because I think that, like I said, that subjective assessment is key. I think personally, if you have a really sound subjective assessment with the hip and pelvis in particular, you can almost minimize the amount of physical examination that you're doing and still come up with a fairly good hypothesis. And the reason for that is because the pattern recognition type of clinical reasoning that we have for the hips can be quite effective, really. And the difference with the hips are that actually we're trying to get to a diagnosis as much as we can do. And I know with kind of that trends, sometimes that's almost like the opposite of that is on trend at the moment with, like, you know, some of the research that we've had with like back pain and things like that, which is understandable. With the hip, we're not at that stage yet, and I'd rather we didn't. You know, I think it's actually useful for us in those situations for those patients to have a diagnosis, because I guess we tend to do things with like imaging and injections to help with the diagnosis a lot more than we would do maybe with other areas. A key thing, for example, with my patients is for me to ask some questions to try and differentiate if it's firstly MSK or non-MSK, because that's quite an easy avenue to go down. So if they're coming in and they're saying to me, my hip is clicking, is catching, is giving way, I've got groin pain, and they're pointing to their groin, you know, that along with their other symptoms, I'm thinking, okay, look, it could be an MSK issue. And then we'll kind of like go down the route of trying to specify what it might be. For me, a differential is like age, for example, is an easy differential, because if they've got those clicking symptoms or groin pain, and it's kind of like giving way and things like that, and they're young and active, then I'll be thinking, well, that kind of fits the potential symptoms of someone who might have FAI. Let's go and have a little look closer down that route. Or if they're coming in with groin pain and it's almost like kind of giving way and they're struggling to walk and they're 80, I'm not going to think that they're FAI. And I've kind of you can use that age as an easy differential. The source of pain and site of pain is the other thing, because obviously if they've got groin pain, we normally would think that would be an intra-articular issue. They're coming in with pain in the side of their hip. And again, if they're female, they're, you know, perimenopausal or menopausal, you tend to think, well, maybe actually that fits more like a GTPS presentation. But then the caveat to that with the hips, annoyingly, is things coexist. So we kind of like have to be mindful of things actually that could have both, which makes our life tricky, but also is why I like hips, because it kind of keeps us on our toes. Now, the flip side to that is they might not have any of those symptoms. They might fit the demographic and you know, where the pain is, but mechanically they might not have those symptoms. And then they might say, actually, you know what, notice some abdominal pain, or sometimes it goes into like the kind of like inguinal area, or I've got pain coughing or sneezing. And those are key questions to ask when you're trying to kind of pinpoint, you know, is it inguinal related? Is it maybe even like gynae related and non-MSK based? And those are, you know, things that would trigger my thought process to start kind of diving in. And I won't bore you with all of them, because there's actually quite a lot of different pathologies that can present with like groin and like lower abdominal pain. So it's just trying to kind of like ask those questions to kind of funnel those out, really. One of the things, and probably the thing I would tell anyone who's reluctant to with hips, is just like try and tick off what you know and with what is within your scope, because we're all trained with backs, and you know, we can easily look at a back and assess a back and try and clear it back. And actually, if you can do that, you're already ticking quite a lot off. So if you're worried that something isn't within your scope, or it's just not kind of, you know, something that you feel comfortable with, well, just tick off all the things that you are comfortable with, and then kind of like funnel it down from there. And then obviously go and talk to seniors and things like that.
Yeah, it always feels to me hips a very complex area. Like you said, there's if you think about muscle attachments, ligaments, the joints that are there's a lot of multi-joint muscles, and there's a lot of very big, very load-bearing joints in a very close proximity, like the sacroiliac joint and the hip joint, symphysis pubis, are all so close together with such big muscle bulks. I think, like you said, you you can have pain in an area, and then if you're not quite used to seeing hips all the time, actually it does fit very nicely a pattern, but you just doesn't even come on your radar because you're, like you said, you're thinking, okay, they're young, I'd probably go down an FAI route, but actually it turns out to be soft tissue, and the question you're missing is coughing. And it always seems to me like, if you go somewhere, like I joked about the shoulder at the beginning, if you go to the shoulder, I always feel with the shoulder, okay, you've got the neck nearby, but the complexity of the load bearing in most people, unless you've got an overhead athlete, just isn't quite the same as in the hip. Almost everybody walks on their hips. And I think that really changes how people understand what they're looking for in the hip. And I liked your bit at the beginning about how people sit, even like go back to that simplicity. Are they getting aggravation in the hip? Because you forget you're in a lot of hip flexion at that point, aren't you? And you're sort of getting into a closed position in sitting. And I think, like you said, people are very quick to, right, let's get you into external rotation, internal rotation, see what's happening. And actually you start a lot simpler. And I think a lot of people would be far better off.
Yeah, definitely. And this tends to be something that I try and avoid as much as I can, especially in those early stages or in the initial consultation. I tend to try and focus, once I get an idea as to what we think is going on through those questionings and like with the things that we've discussed, is to try and just modify symptoms. Because if you've got an idea and you've kind of hypothesizing on something, a lot of the time our clinical tests can't actually diagnose anything. We can rule things out, but the hips, really rife with all these tests that aren't actually specific. Some are quite sensitive, but like they're not specific. So we can't do them and then think, well, actually that's that. We actually have to almost go the other way. So if we can do that and then modify their symptoms by doing the things like we mentioned at the beginning, like doing a squat in a different way or a deadlift in a different way, or just modifying the way that they kind of load bear, like you said, and then that's not painful, that helps our reasoning process. But I guess obviously if they're doing that and that's not happening, and then you've got the flip side of all those kind of non-MSK type concerning symptoms, then that also just helps your reasoning process. And that's just something I'm quite passionate about. I don't like patients being given things or like given rehab without a clear understanding as to like why we're doing that. Because actually you can get quite good results by not doing a lot. But if you do the right stuff and you're giving them the right things to do, could be two of the most simple exercises and actually they'll get better. But if you're kind of throwing a kitchen sink at them and hoping something will work, sometimes it does, and it's annoying because then you think, why has that happened? Why has that worked? Damn it. But it has, but more often than not, it kind of is too much. So it's just about finding that balance, really. But that's why I like the hips. That's why they excite me. Yeah. And that's why, you like your area of expertise as well.
Exactly. Yeah, exactly. I'm all about the complexity. Finally, the last thing I just wanted to ask you a question about was red flags for the hip, because again, that's something I think that people either aren't aware of or don't understand well enough. So I think we're all fairly okay with, like night pain, if they've had a traumatic injury, fair enough. But what other are there any specific red flags towards the hip that you would definitely cover?
I would say, again, to keep it very short and succinct, to two that probably people don't always think of, and why it's relevant. One is prolonged steroid use, and the link with a vascular necrosis of the hip, which is quite important because actually sometimes those aren't questions that necessarily will get asked. And if they are asked and someone says yes, then the clinician might not know why they're actually asking it. And that's always a key thing. I noticed that when I was a junior, you'd ask all these questions and then all of a sudden someone says yes and you think, oh, damn, I don't actually know what I'm meant to do with that. Like, what does that even mean? But actually with the hip, steroid use, prolonged steroid use, or anything which is kind of like an immunosuppressant, prolonged alcoholism, and also sickle cell, are all things that are linked to some potential integrity loss of the bone or the femoral neck or the femoral head that can lead to AVN. So if someone is coming in with hip pain that doesn't fit, and it's sometimes actually, Jack, it does fit, and you think, oh, I've got a patient here with FAI, or I've got a patient here with OA, and you could be a physio in a clinic room on your own with no access to all the other stuff. And this could be someone who's just paying out of their pocket and they can only come for a few sessions. And unless you ask those questions and you're really kind of are aware of why you're asking them, it's easy to kind of treat things and all of a sudden they'll get worse and you won't know why. So those are the things that definitely that I would say. So sickle cell, which is a kind of like a blood clotting disorder, which basically, like, I won't go into details, but essentially it affects the blood, or the marrow within the femoral neck and the femoral head. And then alcoholism, and then like prolonged steroid use. I think those are three key ones for the hip in particular. Like you said, probably because it's weight bearing and load bearing, we'll tend to see it quite a lot. There's a whole heap of other stuff, but like whoever's listening to this will get depressed, listen to red flags if I bang on about it too much.
Perfect. I think we're always, I remember, like you say, when we were juniors, I always think that whenever someone came in with a hip, I think I just went for, as long as it's not the back, it's probably OA. And then you go, oh, but they're a bit young. And then I think I always just got a bit lost. And then you do like a Fadia test, and it wouldn't be painful. You'd be like, oh, I'm screwed now. As if it's not lateral hip pain, I've no idea what it is. And I think you're right. I think it's all about simplifying things down and making sure. And I always think, and I suspect this is something you probably teach on your course as well. I think following roughly the same routine and patterns with your assessments each time, regardless of the joint or the person really, and just fitting it to then what's happening is then you don't miss stuff so much, and you keep it simple and work your way through the simple stuff, because it's pretty unusual that we get weird stuff in, and you'll pick up those more obvious things. We still got to rule the weird stuff out each time.
Yeah, of course. So look, if someone, and I do that, and that's key for, if you're asking someone, do they have pins and needles or numbness, and they're saying, yes, I've got that going down my leg. Well, you don't normally get that with FAI. Or if they're saying to you, yes, I've got pain when I cough and sneeze, you don't normally get that with lateral hip pain. Or on the flip side, if they're saying I've got groin pain and they're 20, well, that's not always OA, but sometimes it can be. So it's just about like trying to go through that list. And sometimes those special questions are the same special questions that you ask. But again, it just always reverts back to, let's try our best to tick off what it isn't, because that sometimes is an easier way of funneling down like what you think might be going on. But yeah, I would definitely always suggest that. I think it's too complicated if physios start trying to think, I'll ask all the FAI questions, I'll ask all the GTPS questions, and then, because otherwise you'll be there for like an hour and nothing will get done, and you'll just kind of like have so much information. Because sometimes patients do, they sometimes say, oh yeah, I do get a little bit of numbness in my leg. And you think, oh, that doesn't fit. And then they tell you it's when they've slept on it for 9 hours and they're not moved. And you're like, well, okay, that's not it. That's not that relevant to that. But it's just picking out that information really, isn't it? Because they've got the answers. We just got to kind of like take it from them pretty much and just like ask them.
Brilliant. Well, thank you very much for spending a bit of your lunchtime with me today. Do you want to just quickly direct everybody to your social media, and we'll put links to your course and your social media into the text as well, but just in case anybody's listening and not looking at their phone or computer at the time, but just tell us what your sort of social media is.
Yeah, so the best way to find me would be on Instagram. So my handle on that is the.hip.physio. I'm also on Twitter as well, and that's on the Hip Physio. My website is thehipphysio.com. All very original stuff, Jack. I'm trying to keep it simple. I've got my hip course is called Simplifying the Hip. So ideal for physios, sports therapists, osteopaths, anyone who basically is keen to learn more about the hip. It's a one-day course. It's online. It's live. It's recorded as well for those who can't make it live. The first 2 dates have sold out already, but we've got places still on the 25th of February. So if you're interested, check it out. It's all easiest way is to go on the website and find it on the hipphysio.com. But yeah, no, thank you for having me. It's been great to talk to you in a very professional format this time around.
A bit unusual for us, isn't it? Yeah, no worries. I was keen to get you on and have a bit of a chat about the hips, and hopefully we'll do some more stuff in the future as well.
Yeah, sounds great. Thank you.